All right, well, it's a great pleasure to talk to you guys today about probably what is my favorite topic, is what's new in transplantation. We're going to talk a little bit, then I'd like to get people involved kind of after about 10 or 15 minutes. We're going to have some questions, so please feel free to enter into the discussion. I think things will get hopefully pretty lively. And just go ahead and get started. Okay, so what's new in transplantation? Well, everything is new in transplantation, so I could maybe go home and have your answer right here, but we'll talk about some details. So this is where we are, right down the street, and a lot of what I'm going to talk about, I'm proud to say, is being done right down the street. So a couple minutes on transplantation. I'm a transplant surgeon. I love being a transplant surgeon. I think transplantation is one of the most amazing things that we do anywhere. The amount of scientific investment and the commitment of the people that I work with every day is really amazing. And this really comes from all of us. It comes from our tax money, the commitment that we have. And I'm going to talk a little bit about, specifically in Tennessee, how wonderful it is to be a transplant surgeon in Tennessee. But transplantation is a treatment for failing organs. Give you some numbers here. 400,000 people have kidney failure, and about 100,000 are on the waiting list for transplants. This is a big problem. There are millions of people that are at risk for liver failure, and about 17,000 on the waiting list for a liver transplant. About 3,000 patients waiting for a heart transplant, 2,000 patients waiting for a lung or heart-lung, and more than 20,000 people die every single year waiting for a transplant. And the remainder suffer with organ failure. I'm sure many people in the room know patients that are on dialysis, or patients that have liver failure, or patients that have heart failure. It's horrible. Our lung transplant surgeon says that, I think in the lung transplant patients are the toughest. He says it's like breathing through a straw. Take a straw and try to breathe for the day through that straw. And imagine how difficult that must be for patients. And so all of our patients, they really suffer. And the reason they suffer is because we don't have enough organs for transplantation. And so that drives a lot of what we do. And we're going to talk about some strategies that perhaps will improve that over time. And the other thing that we talk a lot about is that although this is life-saving treatment, the body doesn't quite understand this. And when we do a transplant, the body thinks that the organ is a problem and attacks the organ and tries to reject the organ. And that, again, is a lot about what I do to try to make sure that that doesn't happen. I'm happy to say, however, that Tennessee is actually one of the best, and maybe even the best, although to try to figure that out is a little bit difficult. But it's certainly one of the best states in the nation for donation. We have a lot of organs here. We have a lot of organs that other states don't have, numbers that other states don't have. And so, for example, if you need a liver transplant in Tennessee, this is probably the best place that you could be, perhaps anywhere in the world. And that's for people like you because of people like you that are willing to donate their organs. So I love this slide, the opportunity of transplantation. What can we offer to our patients? Does anybody know who this is? This is Chris Klew. Okay, Chris Klew won a silver medal in the Olympics. And by the way, he had a liver transplant before he won the silver medal in the Olympics. I love this slide. But I like this one even better. So, as I was saying, they didn't quite get it right here. And although I had no part in the development of transplantation, I do think of it as rocket science. And I have proof that it's rocket science. And here's my proof. And obviously, we never want one of our organs to look like this after it goes in. But here's the proof this is rocket science. This is Joe Murray, a mentor of mine in Boston, who won the Nobel Prize for being the first person in 1954 to perform a successful kidney transplant. Now, when he did it, he did the transplant from an identical twin into their twin. And so we didn't have the problems. It was really more of a technical feat. We didn't have the problems of rejection that took probably 20 years to overcome after that. But nevertheless, he set the groundwork for a lot of the understanding, and just a terrific gentleman. Okay, so where do we get our organs? Okay. Once in a while, I call this guy if we're really desperate, but generally, I can't really call him. Anyway. But we get organs from people like everybody in this room who have agreed to donate their organs. And let me say that oftentimes people don't understand that almost anyone can be a donor. So I've used livers from 83-year-old donors. They work great. They work great. So age isn't necessarily a problem for organs if they're good quality, if they've been taken care of well. So where do organs come from? Well, fairly straightforward. They come from cadavers. These are people who die and gift their organs, or from live donors, from altruistic people who donate to a loved one, a friend, or a stranger. The cadaver donors are then divided into two parts: patients that are brain dead and donors that have cardiac death. So brain death is a definition of death. These people are dead. They're considered dead by society. They have no blood flow to their brain, and then their organs are used. The other way we can do this is through cardiac death, where someone's heart stops, and then they're declared dead, and then we take the organs. It goes without saying, but we never, ever, ever take any organs from patients that aren't declared dead by a physician. Okay, I'm going to get a little graphic, but PG-13 kind of graphic, but if you're a little bit squeamish, you may want to hide your eyes. This is what we do. So this is an organ donation. So these are my hands here. This is a pancreas, and we can do pancreas transplants for patients that have diabetes in certain cases. You can see up here, this is a liver, which we transplant all the time. This is a spleen. We don't transplant this, but just to kind of orient you. So that's what it looks like. That's what we do. And this is a liver that we're actually splitting. So the liver is half the liver on one side, half the other. This half of the liver will go into one patient, and this half will go into another patient. And the great thing about the liver is it regenerates, so that you get kind of a 2-for-1 deal here. So this is a young donor, otherwise very healthy, and we can actually get 2 livers for 2 patients out of 1 donor. So if you think about it, right, 1 donor could potentially give 2 lungs, 2 kidneys, 2 livers, a pancreas, a heart, intestines, and then other things like bone, cornea, and things like that. So 1 person can affect the lives of literally tens of people, maybe even more than that.
Why not 3 out? Seriously.
Yeah, we're not that good yet. And these operations have to be, they're done, the blood supply is really key. And so we have to protect the blood supply, and the liver kind of lends itself to being cut in half, but it doesn't really lend itself to being cut into thirds. Good idea, though. Okay, because we are kind of next door to you guys here, I did want to give you just a couple minutes about our transplant center. So we've started back in 1962, and if you remember, I told you that in 1954 was the first kidney transplant ever in the world that was successful. So we started shortly thereafter. Pediatric kidney transplants the year after that, heart transplants in '85, pancreas, pediatric hearts. We have one of the largest pediatric heart centers in the country, lung transplants, livers, and then pediatric livers more recently. The founding of the Transplant Center in 1989 by Hal Helderman and Senator Frist. So before he was a senator, he actually started the heart transplant program and the Vanderbilt Transplant Center back in 1989. And then the liver program was started by Dr. Wright Pinson. This is just kind of what we do, again, because we're neighbors. I wanted to give you a sense. We are one of the larger programs in the country. This is the number of referrals, the number of organs that we transplant at Vanderbilt every year. We're probably going to do close to 400 transplants this year at the center. And here's my time to brag a little bit. Our center has 100% survival for our heart transplant patients. No other program in the country that has that. All right. Our liver and these are actual survivors, actual survival, and this is what we're expected to have based on how sick the patients are that we do. The government regulates us very carefully, and it gives us a number that we have to meet every year, and that's their expectation for an outstanding program. And we exceed that in every one of our programs here, especially in our heart program, which obviously we're very proud of, but also our lung program has about a 7% improvement over what we're expected to have. Now, but this also points out that these numbers are not 100%, unfortunately. So we still have room to go. And the reality is, obviously, these are big and dangerous operations. Getting back to just kind of the local flavor to this, in Tennessee and at Vanderbilt, we are transplanting patients for each of these organs here. We transplant patients at much higher rates than we are expected to by the government. So this is what the government expects us. And these numbers are absolute, you don't have to worry about really what they mean. But for a lung example, we transplant twice as often approximately as we're expected to. And that, again, is due to you and people in the community that are so generous at donating their organs. So it's terrific. Okay, so we're going to kind of get into the meat of the talk now. So what's new in transplantation? We need to find more matches. We need to find more organs. We need to give them to people that need them in a little bit perhaps better way than we're doing now. We need to improve the matching of the donors and recipients so that these organs don't reject so easily. We need to preserve organs better. We need to diagnose rejection better. We need better drugs. We need new treatments for diseases that require transplantation. We've got to deal with financial pressures, and we will talk about that for a couple of minutes kind of towards the end, right before the big finale, which is going to be science fiction, which is, I'll hopefully convince you, is actually science fact. Okay, so finding more matches. How do we do that? Well, patients come to us sometimes with a donor. So let's say you need a kidney transplant, and you have someone who you say, I've got kidney failure, I need a kidney transplant, and someone that you know, family, friend, says, okay, I would love to donate a kidney. It's a wonderful thing. It's an incredible gift. You come to the transplant center, and unfortunately, you're not compatible with that person. Okay? So what do? You're not set up so that that kidney can go into you because you'll reject it. Your immune system will destroy that kidney. Okay? So this is Alvin Roth, and he, again, kind of in that rocket science vein, he's getting a Nobel Prize, this is last year, in economics. Why did he get the Nobel Prize? Because he came up with algorithms or ways to match people better. So it seems kind of mundane almost. Well, match this person, does it really matter? Well, it really matters, and it's really hard to do. You wouldn't think it's that hard, but it's very hard to do because the proteins that people have that cause them to reject, there are lots and lots of different proteins. And all these have to be fit into an algorithm to figure out how we're going to do this best. All right? And this is what he came up with. And I think in large part, that matching algorithm is what he won the Nobel Prize for. So how does it work? It works like this. So husband and wife, sister and brother, brother and brother. The husband comes in with the wife and says, here's my donor. The sister in Chicago comes in with the brother. And a brother comes in with his brother, and they're in Miami. Okay. It turns out, unfortunately, that the pair in Seattle, which are these two, not the arrow, but this husband, this wife, are in Seattle, they don't match. She cannot give to him, or he would reject immediately. The brother cannot give to the sister for the same reasons. The brother here in Miami cannot give to the brother in Miami. So what do? Well, we got people waiting. So why not have them donate to somebody that they didn't come with? Their partner still gets the benefit of the transplant, they just don't get that kidney. And most of us think that's pretty good. So fortunately, and this isn't always the case, this is just one example, but you can imagine there are lots of different ways that we could do this. We have an altruistic donor. We have somebody out of the goodness of their heart that's read a newspaper story or has come in and says, hey, I want to give a kidney to somebody. Or who do you want to give a kidney to? Whoever needs it. Well, that's great. We love that. This person sets up to give to the wife. So the wife now doesn't need the husband's kidney. They're in Seattle. But the husband matches with the brother in Chicago. Well, that's neat. The sister in Chicago then can be set up to match with the brother, and the brother from Miami can be set up to match with somebody else. And there are chains that go on that are 35 people long. So you can get 35 transplants from this basically from the work of this economist who probably didn't train to do any of this stuff. This is what I love about transplantation, right? You've got all these different things that come in together because we all have this common goal, and everybody agrees this is a really good thing. So this happens all the time. And so this kidney gets taken out in Houston and gets sent to Seattle for the wife. There's another operation going on in Seattle, and that kidney gets shipped to Chicago. The kidney in Chicago gets shipped to Miami, and so on and so on and so on. Okay. Going to switch gears a little bit now. So in terms of matching, though, still, this is Deborah Dodd and Brett Medler. These are the director of our pediatric heart transplant program, and this medical director and surgical director. And what they started doing just recently, did their first one, is an incompatible heart transplant in kids. So what they've come up with in association with some people across the nation are ways to take pediatric hearts, incredibly important, right? You've got a child that's dying, and you don't have a heart for that person. Well, maybe that child is a blood group B. That child could not take a blood group A heart, but you've got a donor with a blood group A heart. Well, these folks have worked out techniques to be able to use that, what we call incompatible heart, from one child into the other. And so we've done this at Vanderbilt a couple months ago. The kid's doing great. So again, the technology comes in, and all those things that people say, well, it's great, you know, they tell me, oh, it's really neat, you're a transplant surgeon, you sew things in. But the sewing part of it is just a small part of it. Right? The operation is just a small part of it. Everything else, all the drugs that we give, all the selection, even people that donate their organs, all those things are equally important. And I think this is a great example of that. So he can sew those hearts in, but without this team together and the drugs that we need and the techniques, it's not going to be successful. This is, as I say sometimes, transplantation is the ultimate team sport. Okay. So a better allocation scheme. So how do we best distribute a limited resource? So we talked about that. We have this, even though Tennessee is great, across the nation we have these incredible organ shortages, and people die because of that. So is there a better way that we can distribute this limited resource? And so actually I'm going to skip that for just 1 second. So let me open it up now a little bit to your answer, keep people, to get some thoughts. So we have, what should be the principles under which we determine who should get a kidney, for example? Yeah.
The health of the recipient.
Okay. So tell me a little bit more about that.
Well, how, their life expectancy
Without the transplant.
would be better. In other words, if someone had so many other problems, and they might have, or they might die because they have some other.
Okay, so someone that would get a good result out of the kidney. So I guess what you're saying is if someone had very bad heart disease and or had cancer, for example, we wouldn't want to do a kidney transplant, right? Because we'd waste that kidney probably, right? Wouldn't get very much time out. So that's great. What else?
What changed a month ago that you could suddenly have very great success on that A to B?
Oh, so those are advances in immunosuppression. So those are drugs that we develop, and then it's one thing to develop the drug, but it's another thing to understand how to use it, when to use it, how to use it. So, yeah.
When you do the immunosuppression, what does that do to the person's life as far as getting cancer or infectious disease? Or
Yeah, so it increases the risk a little bit, but we're talking about dialysis. The mortality on dialysis is about 15% every year. All right. So you're talking about a very small risk of cancer versus a risk of dying 15% every year. So we think that transplant's much better. But let's talk about this other ways that we think are other things that are important for distributing organs.
Talking about Tennessee having a good record on that, is there some distribution by state depending upon each feeding the other?
Absolutely, there is. And so you might think that being close to where the organ comes from is important because you want the people in the community to benefit somewhat from their generosity, and that makes them perhaps generate more organs. Okay? Yeah.
Well, I don't agree with this. I taught a class that dealt with biomedical issues in health, and my students, when we attacked the subject, my students said that they thought that you ought to be able to sell a kidney. There should be a marketplace for kidneys, and that would cut down on limited.
Yep. So that's absolutely. And so it's very interesting, and it would certainly help. Now that's something that I've thought a fair amount about, but I think it's against the law to do that. It is. But I can tell you that the head of the surgical group for Transplantation United States and the medical group for Transplantation United States have both come out recently in favor of a regulated market for kidneys. So it's not something that I talked about here, but it's very new, and it'll be very interesting to see how that goes. Yeah, one more comment in the back, and then we'll move on a little bit.
As a spokesperson for the American Liver Foundation, I got to sit in on eligibility, and I was very surprised that they actually talked about the psychosocial and support systems that the patient will have when they go home.
That's great. Yeah, absolutely. And so I think, and that gets to the comment earlier here, is that we got to make sure that that organ is used and gets a life out of it. And so that the reason that that's important is because if someone doesn't have the social supports and they go home and they don't take their medicine and they lose the organ, or they can't get transportation back and forth to the hospital to protect that organ, take care of that organ, that's something that we do think about a lot. We want those organs to get used as efficiently, effectively as we can. So I don't know if anybody knows The Onion. It's one of my favorite newspapers. It's kind of a joke paper, but Julie Paris, Julie thinks that the organs should go to those that have the fewest, and I guess she only has a left lung and a pancreas. But I don't think that this is a joke slide. But I think we have to be much more thoughtful about where these organs actually go. So how would you design an allocation system? We talked a little bit about the things that we think are important in this group. And I'll add another few to you. Time waiting, right? So is there an issue that we want some fairness in here? We don't want people to have to wait too long. If you've been waiting for a kidney for 2 years, or if you've been waiting for a kidney for 6 years, should that matter? How much should that matter? How sick is someone? If you need a liver transplant, for example, if you're doing okay versus someone that is in the intensive care unit, do you want that liver to go to someone that is in the intensive care unit, or do you want it to go to someone who's doing better? Cause of the disease. What if they have a disease that's likely to recur? What if they have a big cancer and you think that, oh, they're just going to get their cancer back again? We don't want to do that. So likely outcome. How close they are where the organ is donated, and then do we give priority for children? So all these things are very important. And
Who makes up the final decision?
Yeah, so this is made by UNOS, and UNOS is the United Network for Organ Sharing, and they're contracted by CMS, Center for Medicare Services, which is a governmental organization. And so those decisions get made through UNOS. And UNOS talks to the transplant community, gets input from a lot of different people, and then we go ahead with the recommendations. Yeah.
Are there figures for how many or what percentage of transplants fail within 90 days or 6 months? Or some such figures?
Yeah, absolutely. And so you can go, this is one of the things that is interesting about transplantation, you can actually go to a website and you can get that data for the country, you can get it for the state, you can get it for every transplant center, you can get it for every organ, you can get it for patients between 35 and 40 years old who had their transplant done in Nashville, Tennessee between 1991 and 1992. I mean, all that data is publicly available. I know where to get it. It takes me about 12 seconds to get there. If you had to Google it, it would probably take you a minute or two. So I want to try to move along because we got a lot to talk about. But I wanted to say that this is now coming up to the fore, and I wanted to kind of new things. I wanted to let you know. So the current allocation scheme right now is basically for a kidney transplant, you get, if you're waiting longest, you get if you're on dialysis, you're waiting a long time, you get the kidney. Okay? And what's being proposed now is to segregate these groups into basically the healthiest 20% of patients that will get the best quality kidneys. Okay? So why might, and health is determined by a lot of different things, but one of the key criteria in health, you may be able to guess, is age. Okay? So what's going to happen with this new system that's being proposed is that actually, because the older patients aren't considered as healthy and aren't expected to live as long, they're going to get kidneys that perhaps aren't as good. Quality's not so good. At the end of the day, the idea is to get each kidney the most life it possibly can, because although you might put let's say you put a 20-year-old kidney into someone that was 70 years old, the 70-year-old died at 85, they got 15 years, but that's a perfectly good kidney. And so whatever more years on that kidney you would have gotten, you've lost those now. Whereas if you put that 20-year-old kidney into a 20-year-old patient, you could get 25, 30 years out of it. So I just want to give you kind of a flavor of how those decisions are getting made. No, it's very hard. It's a good idea, but it's very hard. And so again, for liver transplantation is a similar issue that there are, so let's say patients in New York or California that, in New York, I don't want to pick on New York or California, but they tend to have fewer organs than Tennessee has. So as a result, patients in Tennessee that are a little bit less sick are getting organs, whereas patients in New York, California that are sicker maybe are waiting longer for organs. So there's a proposal to send those organs from Tennessee or places like Tennessee out to places like New York, California that have higher scores. And so is that fair? Is that just? It will probably decrease the number of deaths on the waiting list, perhaps, but does it take away from the local community and the local interest and the local, for lack of a better word, generosity? So.
Can you so designate that if I donate it here, it's got to be used here?
Yes, you can. You can. Yeah.
Are you restricted to being on the waiting list only in the state in which you reside?
No, you can go anywhere. And in fact, Steve Jobs got his transplant in Tennessee. He flew in from California when the liver was available. So. Okay, I'm going to actually try to hold questions till the end now, because I do want to get through a bunch of stuff. So ultimately, I think the take-home point is that there are ethical principles here of utility versus fairness, and these things have very important political implications and ramifications. And these are things that, these allocation schemes and systems are things that the senators actually get involved with. Okay, I'm going to skip this part and talk a little bit about this. So we talked a little bit about preserving the organs, okay? So the organs don't like to be refrigerated. So when we take them out of the donor, we put them on ice for a while. And it's, if Thanksgiving's coming up and you put your turkey in the refrigerator, right? The next day it tastes a little bit better sometimes, right? I like that kind of one day. Well, organs aren't like that at all, right? They don't like to be put in the refrigerator. And so we have some ways potentially of, once those organs come out, of actually having them do better. And so this is a brand new machine, and this machine perfuses this inside. I'm sorry the picture didn't come out so well, but this is a perfusion device, and what's in here is human lungs. And this is a physician who is taking a look at the lungs with a telescope. This is a picture inside the lungs here. But this machine basically pumps oxygenated fluid through those lungs to improve those lungs, to protect those lungs. So this is a way where we can take some of those lungs that we might not ordinarily use and use them, again, because there are patients dying. Think about those patients trying to breathe through that straw that need these lungs desperately. I think we'll skip that. So the same thing for livers. So this is a piece of a liver. And you can tell this is kind of a nice glistening surface. It's kind of a gray color. It looks really nice to my eyes. But I hope that you will agree, I may be wrong on this one, that this liver doesn't look so nice. All right? So this is a liver, and I want to kind of, again, contrast the two livers. Nice, not so nice. And like this is like really not nice. Right? You don't want a liver. You don't want to even live with a liver like this. But this is a liver that was used. This is a liver that we put on not me, but it was put on a pump, put on one of these devices, and actually allowed this liver to be used, and the patient did great. So new technologies of being able to take, once the organ's out, to be able to perfuse it, oxygenate it, and actually pep it up a little bit. Yeah, so for kidney is the most important. For the liver is not so important. Okay. I think what time is it? Maybe we'll skip this. So I'll just talk for a minute. About this, and we'll move on. It's really important for us to know if somebody is rejecting. There's a lot of reasons that the organs might fail, and rejection is only one of them. But in order to make a diagnosis of rejection, you need to have a biopsy. You need to have a piece of tissue. And so the holy grail for that part of the talk is a way that you can test the blood or the urine to see if someone's rejecting. And in heart transplantation now, I think we're pretty close to finding these markers. For liver and kidney also, we have many proteins in the urine and the blood that are higher in patients that have rejection. So wouldn't it be nice to be able to take a urine test and say, okay, you have a rejection instead of getting a kidney biopsy. Okay. Next is genetic testing to predict medication dosing. So as we talked about, we can't have the organs rejecting, but if we give too little dose of the drugs to prevent that from happening, the organs will reject. If we give too much, and there was a question that was alluded to before, if we give too much of these drugs, patients get infections. So we got to be just right. And how do we know? Well, what we do is we check levels on these patients in their blood, but we got to get it exactly. And so one of the things that we're pioneering, again, I'm very proud of at Vanderbilt, is Predict, and you may have seen some TV commercials where we talk about this. This is a resource to tell us how you are going to process each individual, how they're going to process different medications. So one of the big drugs that we use is a drug called Prograf. Prograf is the primary drug that we use to prevent rejection. People need very different doses of that drug. There are some patients that we have that use 0.5 milligram of drug given once a week. There are other patients that need 12 milligrams a day. All right? So this is a difference of, or actually a dose, so it's a day it's about 20 milligrams. So it's a difference of like 0.5 milligram a week to about 100 milligrams a week. So there's a 100-fold difference in the amount of drug that between different types of patients. So how great would it be to know about that beforehand? And we can do that now. And so what the program does, there's a particular enzyme that we know metabolizes, breaks down the drug. And depending on what flavor you have of that enzyme, we know if you're going to break the drug down quickly or slowly. And if you break it down quickly, we got to give you more. If you break it down slowly, we got to give you less. So this clinically helps us dramatically. So we want to give the right drug, the right dose the first time, right from the beginning. And it turns out that probably this is cost effective because you prevent complications. Okay, a bunch of new anti-rejection medicines that I'll talk to you about. And I think the reason I want to, the point I want to make here is not the names of the drugs or kind of exactly what they can do, but to understand that the reason we have these drugs is because we understand the science behind it. There have been 20 years of work looking at which molecules, which proteins are important for these reactions. And then once we understand it, we target drugs. And a lot of the drugs that I'm going to be talking about are based on our own immune system. So they come from our body's ability to make very specific drugs against other proteins. So all the science that comes in is absolutely essential. So a bit of a complicated slide, but these are the immune cells, and they have all, so this is the blood cell here, and on their surface they have different receptors, which is how they get and give information, how information is passed. And by blocking these receptors specifically that are involved in the graft rejection, we can prevent the rejection. Knowing about all of these specific proteins and how they are put onto the cell is absolutely essential. And we'll go through a bunch of different drugs. This is one of them showing improved survival in patients after kidney transplant with this brand new drug. Here's another drug again. This is a metabolic pathway, and only because we understand this metabolic pathway we can build a drug that works right there. This is an immune response pathway, and we block it right here because we understand the pathway so well. Okay? And it improves rejection rates from 40% down to about 10%, a little less than 10%. Again, another pathway. We understand this is the cell membrane. The cell is in here. This is the nucleus of the cell. This is the signaling from outside the cell to inside the cell. And we have different proteins which affect the cell, and we block this pathway, and we can prevent rejection. Okay. Another one. Very complicated slide, but the point of the slide is that we have to understand, this is again another cell here. We have to understand all of these pathways in order to come up with this drug, which also prevents rejection. Okay. Switch gears a little bit to something that I think is incredibly important, hepatitis C. I'm sure people in the audience know people that have hepatitis C. It's a terrible disease. Destroys the liver. Generally takes 25 or 30 years for that to happen. And up until literally a year ago, we had very poor therapies for hepatitis C, but within the last year, we've had 2 new drugs that have come out. They're incredibly good, and they cure hepatitis C in 70 to 80% of patients. It's terrific. It's just great. It's good. It's good. You know, every transplant surgeon who's worth his salt, wants to put himself out of business, right? I mean, we don't want to do transplants. We want to get people before they get organ failure. And I think this is a great way to do that. But for me, as a practicing surgeon, this is also good because the patients that get a liver transplant who have had hepatitis C that destroyed their liver, they get the hepatitis C back again. And so the additional drugs after they get the transplant to get rid of the hepatitis C is very valuable. And so we can use it in patients that have never seen any drugs before, but we can also just say that the drugs are very good. And we can use them in patients that have already been treated. So if you've failed treatment before, you have hepatitis C, try one of these new drugs because there's a very good chance that it can cure hepatitis C. And I can't even begin to tell you how much work has gone into understanding how the virus works. And going back to the late 90s, we didn't even know what the virus was. We called it non-A, non-B hepatitis. No understanding at all. And we've gone in that short period of time, 14 years, from no understanding at all to now a therapy for it. It's amazing. The pace of medicine is just absolutely incredible. Which brings me to this slide, which is a real problem. We are increasingly not able to afford all the research that I've talked about here. This past year has been a very bad year for medicine in America. Our Medicare reimbursements have been cut significantly, and we have a lot of pressure from third-party payers. Grant funding lines from the National Institutes of Health have never been as bad as they are now. People are leaving science like crazy. Funding lines, so what I mean by a funding line is if you submit a grant, the United States government, and you guys all sitting in this audience, you fund almost all the research, and I would say you fund probably 60% of all the research done in the world and probably 95% of the good research done in the world, to be honest. But the ability to get those funds is getting tougher and tougher. It used to be that a grant you submitted to the government would have about a 30 or 35% chance of getting funded, and now it's about a 6 or 7% chance of getting funded. And here's the other kicker. Remember I told you about that child with the incompatible transplant? It's incredibly expensive to do that transplant. Incredibly expensive. They need more resources. A lot of what we do, a lot of what you've seen here in terms of the technological advances are incredibly expensive. In the long run, it saves money like you wouldn't believe. So a kidney transplant versus dialysis. Any thoughts? So if you're on dialysis, what do you cost the government versus a kidney transplant? What do you think the difference is? How much do you save? How much does a kidney transplant save the government? It's about. So we're just talking about what it costs for a year of dialysis versus the medicines to protect the kidney. It saves the government about $40,000 per patient for each kidney transplant. All right. So if you do that up, if you multiply that out over the number of people with kidney transplants, it's tens of billions of dollars. All right. But when you first started doing the transplants, they were really expensive. Okay. So that investment is incredibly important, and that's I think what's really at risk here. What does the transplant itself cost? The transplant itself is probably $60,000, $70,000, something like that. So you make that up in the first year and a half, because the dialysis costs about so dialysis itself costs actually more than that's the difference. But dialysis, you make it up in the first 1 to 2 years, the cost of the transplant. Plus, you have much better quality of life not being on dialysis. You live longer, much longer. Patients that have kidney transplants go back to work. They become productive members of society, whereas being on dialysis is. Some people can work, some people do the things they want to do, but most people it's very, very difficult. Okay, so now the fun. Science fiction, which is not really science fiction anymore. So the problem is that there are not enough organs. This kind of plagues us. This is what I wake up in the middle of the night sweating, worrying about. This just shows you the hundreds of thousands of patients who are on dialysis and who are waiting for organs. So this is something that we're working on at Vanderbilt. It's a total artificial kidney. So instead of having to have a donor, put a little machine in here, hook it up however you want to. But the idea is to be able to get blood into this filtering device, send it back to the heart, and have a little tube to take the urine that this makes and put it into the bladder. Now these studies are very, very preliminary. This is what the device looks like. It's pretty small. It's about that big, size of my hand. And we've done a bunch of experiments with this, and we've actually gotten some urine out of this device. Okay? Now this is not going to happen tomorrow, but you got to do this step before you can do 100,000 of them. Right? So these are things that this is no doubt in my mind. This will eventually happen. Will it take 10 years or 20 years or 30 years? I don't know, but pretty neat to have basically an implantable kidney. Yeah.
Are you using any animals? Because I know they use pig hearts.
So animal hearts. So organs from animals. There are a lot of concerns about organs from animals, and we haven't gone over those barriers. We haven't breached those barriers yet. So their concerns are for infections to transmit from one species, pig for example, to a human. So diseases that previously that humans couldn't catch. There's concern that if we put those organs into a pig organ into a human, that virus could change and be able to infect humans. That's a concern. But the immunologic barriers, which is to say the ability to get a heart from a pig into a human and not have that reject, that is still too big of a barrier right now. But it's something that's being actively worked on. So artificial organs, pediatric artificial heart, this is what it looks like. They're tiny, absolutely tiny. And these are not, so when I first got into transplantation, started being interested in it in kind of the early 90s, I was thinking, wow, it's the most incredible thing. You could implant a heart. You could take a heart of yourself and implant a heart. Amazing. And now we've achieved that, right? As of the last few years, we can put these into kids, and we can put bigger ones into adults. And they're called ventricular assist devices. They're totally implantable. Dick Cheney had one for a while, right? So this is a technology. And imagine the tens and perhaps hundreds of billions of dollars it took to develop that technology. And now we are seeing it. And a lot of that is public money that comes from the government. So even better, if we, as much as a transplant, as great as that is, imagine just taking a heart off the shelf for a child that had heart failure, or a kidney off the shelf. Almost finish up. This is something that's very new, last 5 years or so, and this is I believe this is the first person that ever had a face transplant. So oftentimes what happens is that there have been patients that have been burned with acid, patients in fires, patients that have been mauled by dogs, and they have no face. And this is what it looks like. It's not perfect, but it's pretty good. And this is something that has really come along and will continue to come along. And so sometimes, although I haven't been doing this for that long, sometimes this is kind of what I feel like. Let me try. I want to get the audio for this. No, I'm sorry. I'm sorry that the audio doesn't come up. Anyway, he talks about I'm not a magician. I'm just an all-time country doctor. It's great. Thank you for your attention. Happy to take questions.
I would like to know what makes you unable to give an organ. Are there certain diseases that preclude you being an organ donor?
Absolutely. So the first thing that I am concerned about in a donor, the first 5 things are safety of the donor, the safety of the donor, the safety of the donor, safety of the donor, safety of the donor. Right? We don't want to hurt anybody by doing this. And so we got to make sure that the donor can safely tolerate a big surgery, which is what all these donor operations are. So if you have significant heart disease, it's too dangerous. If the organ that you want to donate is not in great shape, probably not, you're not going to be a great donor. But I think that's really what we're concerned about, making sure that we don't put the donor at risk and making sure that that organ is going to function. Yes. So I think that, we are concerned making sure that that organ is going to function well. And so, although age is not a strict criteria at all, if you had significant kidney disease, then you wouldn't be a kidney donor. But if you had a kidney disease and you could be a liver donor, for example, or you could be a heart donor. If you had heart disease, you wouldn't be a heart donor, but you could be a kidney and a liver donor. All right. Lots of questions. Okay. Well, we'll try to kind of go this way and go around. Okay.
Can you take half a liver from a living person and transplant?
Yes. Yes. It's dangerous, though. And so there are only a few centers in the country that do that. There have been a couple patients that have died, donors that have died, which doesn't fit my 5 criteria, right? So I think in certain regions of the country where it's very desperate, that's a good operation, assuming everybody understands what they're getting into. But in Tennessee, I don't think it's a great operation because for the most part, we don't need that. Okay, up in the back there. So, no, that's definitely not science fiction. That's dangerous because you have to irradiate the recipient. So you have to get rid of their own bone marrow. And although when the bone marrow comes with the organ, generally you're not going to reject because the immune system, the bone marrow is really the immune system. You won't reject that organ, but you have to have a period of a significant amount of time where you have no immune system whatsoever. And so that's something that has been used for a very few patients, but less than 1 in 10,000 patients has had that type of a therapy. So. Yes, there's a bunch of labs that are doing that type of work, absolutely. Yeah. Yes, it depends on what type of cancer you had and how long ago it was. So the question is, if you use the artificial organs as a rejection problem, go away. Yes, absolutely. So, but to be fair, it brings its own problems. And infections with these artificial devices generally are actually much worse. You might not expect that, but generally they're much worse than if you use an organ, use a tissue organ.
If a person is in need of an organ transplant, is that transplant the organ itself going to come through the medical center that individual is associated with, or do they go on a national kind of search?
So great question. So you are a recipient is so you're asking about the donor or the recipient?
I'm talking about a recipient.
Yeah. So the recipient is associated with a center, but the list for the organ is not associated with the center. So for example, we have our region around here, which includes basically middle and eastern Tennessee. That's our region. And so if you get on the list from Vanderbilt, or you get on the list from Knoxville, or you get on the list from Chattanooga, it's the same list. So if an organ is offered, it doesn't matter which center you came from, it'll go to you, and then you'll go to your center and get the transplant at that time.
What's the issue now with West Tennessee and the idea that they're coming in and St. Thomas is going to become a liver transplant center because they're associating with Methodist Center and UT's operation in West Tennessee?
Right, so if they want to open up a transplant center, they can do that. If they want to start doing liver transplants, they can do that. And then presumably they would take their patients from Memphis and list them here as well.
Would they have the same sources of organs then?
Yeah, so they would have access to the source.
So that would, in essence,
That's correct. That's correct.
How much time do you have to get the organ after someone's dead?
Yeah, great question. So after they die, if they're brain dead, as long as the heart's still beating, so remember that someone can be dead but still have a beating heart and lungs that are working if their brain is dead. And if that's the case, you have time, a few days probably. But once the organ is out, when it's in that refrigerator, it depends on the organ. Kidneys can usually last about 40 hours, something like that. Heart's really 5 hours. You don't want to go much past that. So
Suppose you can't control the time of death. I mean, it's
So if the death occurs in what we call an uncontrolled fashion, if the person just dies, then we generally won't use those organs. So I was asked to actually be on a committee that part of the New York City public health system, where what they wanted to do was they wanted to try to use organs from people that died and were found. And it's an interesting idea. I declined, actually. I declined to be involved with that project, and the reasons that might be obvious to you as to why that is. But because I think you get into some dicey questions there of public trust. So let's say that you have somebody that's down and you're rushing, you take the organs out, but it turns out that that person didn't want to be a donor, or there's a family member that had an issue with that. We depend on trust. I mean, what I do every day depends on all of you. That you have to be comfortable with the system, you have to be confident that I'm going to do the right thing, that I'm going to take good care of these organs, because if you don't think that that's the case, you're not going to donate your organs. And we all need that to happen, and our patients need that to happen. So the trust is important. And so that, I'm not a huge fan of those type of policies or procedures. Yeah. How are we doing on time? We have more time?
Take one more question, I believe.
Okay, all right. One more. Who hasn't asked one yet?
Suppose you want to give your organ to a recipient, you come in, the two of you. Turns out that they're incompatible, okay? But I agree to give my organ anyway to whomever.
Yeah.
Can my recipient, because I wanted to do it to that person, can that person have a move up thing to be on the list for one that is compatible?
Yeah, so we used to do that, but it's tougher. It's getting tougher and tougher to do that, and those are based on government regulations that they kind of frown upon that. And there are some reasons we could. I'm happy to hang around and talk more about that, but there are some reasons which I think are reasonable why that's not. But we could find a swap for you, another pair that was similar to you, and then do the swap.
Yeah.
Okay, I'll hang around up here if people have more questions afterwards. But I really appreciate your time and attention. Thank you.